Greetings. Greetings and welcome to our final Telemedicine Hack office hours number 5. This session is our follow-up from our September 16th session named The New Normal, Tips to Making Telemedicine Part of the Permanent Practice. Today we have 8 expert panelists with varied backgrounds and specialties to answer your questions. I'm Captain Darren Daly of the United States Public Health Service and the U.S. Department of Health and Human Services. This session will be going for 75 minutes versus our normal 60 minutes. The last 15 minutes, we will present information on how to obtain your ASPR certification, access to series resources, final survey input, and the new process to register for the upcoming telemedicine series with our TRCs. As a reminder to our audience that this is a fast-paced series designed out of public health community needs for ambulatory care providers and supportive staff, in preparation for current and possible fall COVID resurgence. This is an interactive peer-to-peer learning module with case studies and discussion boards. The more you interact, the better the learning experience. Our goal is to have at least 90% of participants conduct and bill for 1 or more video-based telemedicine visits just in 7 days, September 30th. Currently, we're at 84% of that goal, and we need your help in breaking the goal. You can do this by taking the end of the series survey. The survey will be linked to you into an email at the end of this week. Next up is Dr. Bruce Struminger with Project ECHO at the University of New Mexico. Bruce.
Thank you, Darren, and welcome everyone to this final session of the Telemedicine Hack series. It's been really an amazing adventure over the last 10 weeks, and we're looking forward to today's session. Just a word about data use. We just want to remind everyone that Project ECHO at the University of New Mexico takes data stewardship seriously, and we really are guarding your data and making sure that it's kept safely. Next slide. Just a few notes about logistics. We really appreciate your questions. It's really what keeps things dynamic. Your questions coming in through the Q&A. We have quite a number of experts on our panel who will be monitoring the Q&A and answering your questions, as many of them as they can. And so please put questions and comments about today's topic in the Q&A section at the bottom, access through the toolbar of Zoom at the bottom there. If you have any technical or logistic issues, please put those in the chat. We'll try to address those as best we can. This session is being recorded, and your attendance is consent to be recorded, so thank you for that. We'll be sharing the recordings through the Project ECHO Telemedicine Hack website. We'll put a link to that in the chat so that you can access prior recordings, and that will be up as long as you need to access it, along with all the PowerPoints over the last 10 weeks. There will be continuing medical education and CPD credits about 15 minutes before the end of today's session. We'll share a link to the survey. We really appreciate your feedback. It's really helped guide us in the design of this series. And as we move into the next phase, which you'll hear more about, through the telemedicine resource centers, all your feedback will go into the planning and design that will follow. So please take the time, 2 or 3 minutes, to fill out that survey. Next slide. One thing I also just want to remind everyone is that we're keeping our focus of this learning session on patients and health systems and supporting providers to be excellent telemedicine providers, and just want to keep things apolitical and non-commercial. So thank you in advance for that. So just quickly about today's agenda, we've got one case first, which will be a case presented by Dr. Anita Patel, who's an associate professor and chief of the Division of Geriatrics and Palliative Care at UT Health San Antonio. After that, we'll have a few minutes of Q&A, and then the balance and majority of our session today is going to focus on Q&A with our panelists, our presenters from last week, as well as our panel of experts who will be joining us. So my colleague, Dr. Christian Ramers, will be facilitating that, and I'll introduce him in just a moment. But first, next slide. Great. It's really my pleasure to introduce today's case presenter. As I said, it's Dr. Nita Patel from UT San Antonio. And Dr. Patel, again, is the Associate Professor and Chief of the Division of Geriatrics and Palliative Care. And what's important is that she serves a population that is primarily Hispanic, about 65% Hispanic. And she is considered really one of the best physicians and geriatricians in her area of Texas. So it's really an honor for us to welcome her to this session of the Telemedicine Hack. Dr. Patel, the floor is yours.
Thank you, Bruce, for the kind introduction. Next slide, please. So as our practice of geriatrics and supportive care, even though we are in an academic practice with UT Health San Antonio, with the Health Science Center here, it mainly functions as a community or private practice. We are housed in across the street from a hospital where we have a consultation service for geriatrics and palliative care. And we have collaboration with a lot of resources that our patients need. So primarily our services is we are primary care physicians as well as specialty care for both geriatrics and supportive care. We serve a population of approximately 3,000, about 64% Hispanic, and 24% are in our underserved communities of town. Before COVID-19, telemedicine was less than 5% of visits, and it was mainly in collaboration with our home health agencies and hospice agencies where they wanted the home health nurse or the therapist would want us to see the patient, see a rash or a wound, and we would just document it, but we were not billing for those services. But after the COVID-19 peak from mid-March, we really increased our telemedicine services, and we had anywhere from 90 to 100%. All our visits were telehealth. And now we've gone back to seeing a few of our patients face-to-face, especially home visits, and many still continue with telephone and video visits. Next slide, please. So the Cariños en su casa Care for You at Home is a model of care that we've developed over the past few years. It's almost taken about 7 years, and it's a decade now since we've been practicing this approach of care for frail older adults here in South Texas. We started with our outpatient clinic and focused on what the patients need, and it was all relationship building with our acute care of elders program that is in the hospital. We had an ACE unit initially and now changed it to a consultation service. We collaborated with select rehab, post-acute and skilled facilities and long-term care facilities. We also narrowed down the number of home health agencies and hospice agencies we work with, so that it's like a relationship, and they have access to us and we have access to them. And the primary focus in the center is our patient and team. So although cariños is a mnemonic, cariños in Spanish means fondness, tenderness, and love. So the key points of our approach of care are the care is comprehensive and coordinated. We are always advocating for our patients and families. We really respect what matters most to our older patients. It is their preferences and their wishes, focusing on the 4 M's of age-friendly health systems. And all the activities that we do have to be intentional, and processes need to be constantly looked at and changed to specifically meet the needs of our patients. Nurturing the relationships, and this is so with all the community resources as well, the senior centers, with the consultants, with the DME companies, Alzheimer's Association, cancer centers. So it's really important to form a patient-centered or patient-driven neighborhood, as we call it. And really, our patients know what they want. We always don't know it all, and it's important to listen to what they say and really what matters most to them. And of course, many of our older adults have multiple chronic conditions, and supportive care becomes a very important part of caring for them. So we integrate supportive care to focus on the quality of life for them. So we recently changed the name of our practice from geriatrics and palliative care to supportive care to be culturally congruent to the Hispanic population here. Palliative care has like a negative connotation, and supportive care, we would say that you have too many medical conditions, you're frail, and you're needing a lot more support other than just the medical care to have a better quality of life and take care of the chronic conditions you have. Next slide, please. So about our telemedicine in COVID times, as an organization, UT Health decided to work together to start telehealth visits for all our practices, and we had extensive leadership support and worked together as a team with IT, billing and coding, clinical operations, a lot of the medical directors and practice managers. Everybody came together to set up a way of working together to make telehealth work. And how do we troubleshoot if patients had a problem logging on for a video visit or a telephone visit. We had to do extensive training for our staff and clinicians, patients, family, caregivers, and handouts. And we had something called as virtual red coats. These are all our IT and EMR folks who are present and available to us 24/7 to troubleshoot any problems connecting for telehealth. We did have intentional processes and follow-up. We had specific telemedicine visit types created in the EMR to make it more easier, and for the billing and coding to be more intuitive and automatic rather than having to do it later. We had to have extensive pre-visit preparation. The staff would call the patient, make sure that they've logged in correctly and they are not having any issues logging in. And we have daily and weekly huddles to look at how the telehealth visits are working. Next slide, please. So despite telehealth and despite us having a lot of visits, almost 100% of our visits as telehealth visits, there were a big chunk of our patients that we were not able to reach because of telehealth, because they did not have access to technology. And with the COVID-19, many of them did not have access to telephones too, because the primary person who was earning and paying for their phone, many of them lost their jobs or were let go. And so we tried to see how could we focus on patient and how could we get them what they need. Okay. So initially we started collaborating with our home health teams. So many of our patients who were on home health, we coordinated with our home health nurses or the therapists and coordinated the telehealth visit with the visit when the home health team member was at the patient's house. And we did the FaceTime visit with them with the patient's consent and took care of the patients together collaboratively. But there were many patients who were really not on home health also. And so how do we reach them? And many of our patients, especially in the west and south side of town, are uninsured or underinsured. And so we have a project that we were pilot testing from January of this year called the Cariños en Su Casa project, where we have 2 promotores or community health workers who work along with us to reach this underserved and uninsured population. Initially, before pre-COVID, in the months of January and February, we used to see these patients in the community health center. But with COVID and lockdown, we were not able to see the patient in the community health center, and we had to go to the patient's homes. So some of the patients were really not very keen on having us as healthcare team go to them, but they were okay with the promotor or promotora going to their house. And so the funds from the grant we redirected to actually getting an iPad and hotspot so that the promotor could then FaceTime with the patient's consent to us, and we could provide healthcare services and meet their healthcare needs. Now we were also collaborating with the community health center. It's not open for the general population, but it's a huge, large space. So we are doing face-to-face visits there. Or if the patients don't want the promotor or the promotora to go into their house, then they are allowing them to come one at a time to the center, and they are offering telehealth visits for them through that avenue. Next slide, please. So we just had to get creative, keeping the patient as our focus, like how can we get them the services they need. So initially our Cariños and Su Casa program was more promotora or promotor-led. That is the community health worker led, and they have the trust of the patients and the community, and they would direct us and let us know when is an appropriate time to actually go and do a home visit. And so since we had that relationship, we built on that to have telehealth services using iPad and hotspots, giving the promoter, the community health workers, the iPad and the hotspots. Next slide, please. So my telemedicine life hacks are basically, if patients and people don't have the technology, then you take the technology to them. We've used our community health workers. We've also used the home health and hospice agencies to provide the telehealth and technology that patients need. Be creative and innovative in using your patient-driven neighborhood. So I think we've really, through our Cariños and Su Casa approach, we have developed relationships with 4 different home health agencies here. And they will go anytime. They go after hours, they go on weekends, whenever the patient needs. So we've kind of done a lot of acute same-day visits to prevent the patients from going to the hospital and the emergency rooms, especially in these COVID times, using our patient-driven neighborhood. And collaborating with community centers, like San Antonio has really a lot of community centers by the county, and all of them have really shut down. But they all have a lot of computers and Wi-Fi that could be used as ways to get patients with the social distancing and keeping the safety to get telehealth services with their healthcare team. Next slide, please. Thank you all, and I'm open to questions.
Dr. Patel, thank you very much for that wonderful and inspiring presentation. I really love the way you've been incorporating the use of promotores and community health workers. And I think you've got a secret special approach there that really will give you an amplification of what you're doing. My first question was about, what special methods you found to help you be more successful in engaging geriatric patients with telemedicine. I'm sure the promotores who know those patients well, having them show up at their door has been a tremendous help in engaging those patients. Anything else that you've done though? So
our practice has been kind of divided. Like we have one set of our patients who are really very tech friendly, and they'll be even in the waiting room with their iPads or their phones. And the majority, 65% plus, where technology is a challenge for them. So for many places where we do not have the promotores, that's where we use the home health and the hospice, but we've also used family. So many times the children or the niece or, neighbors also, so we ask the patient, is there anybody who can help you? Because a video visit is more meaningful than a telephone visit. A telephone visit is better than no visit. Okay? But at least you get to discuss the important issues with the patients. But so we were keeping the focus on the patient and how to get what the patient needs really got us to be a lot more creative and find answers for resolving the issues that they have. Many of our patients are also like in assisted living and independent living communities. So we've got the leadership and the management and executive leadership of those facilities to help us with the telehealth visits. Yeah, I failed to mention that, but so they also had the iPads and with the patient consent, and they had a separate room where they would bring the patients. The most important thing for geriatric patients that we found these telehealth visits to help us with was to do their home assessment. So telehealth visits actually takes us more time than a face-to-face visit, because the patient, they're isolated and they wanted to show us their house and their cat and their dog, and this is the porch where I sit in the sun, and then we want to do a home safety eval. So we ask, can you take it to the bathroom for us to see if they have any grab bars? Are there any stairs in the house? Is there enough lighting in the house? So it's actually done a lot more good than we thought it could do, the telehealth visits.
Great, thank you. I mean, given that seniors in particular have been socially isolated during the pandemic over the last 6 months, seems like the promotores going into the house and doing what you just explained with the sort of augmented home visits. Do you feel that's helped with the social isolation and addressing that issue?
Yes, to a great extent, it has helped. And so we even like now have a combination of where we will do one visit as a home visit or a face-to-face. We'll go with the promoter and do it, and one visit as a telehealth visit, just because of the social isolation. We wanted to see that, because many of these independent living, assisted living places, they do not allow even family to come. It's all only a window visit. And so because they allowed healthcare, they looked out at the promoter, and it also helped the family members, because the promoter will even contact them, do FaceTime with the family, so that the family can get to see their loved ones as well.
Great. And my last question is how you see this increased use of telemedicine becoming a permanent part of your practice?
So I think we already do have visit types, and we kind of have started with like having one face-to-face visit and offering the other visit as a telehealth visit. Patients, many of our patients requested, like many have actually liked it and said, oh, maybe I should just come by to your office to see you once a year, and the rest of the time we can just have visits on the video. I just love these visits. I don't have to worry about transportation or my daughter having to take the time off to bring me, and I get the same service that I get when I come and see you in person. So. And they also feel like we spend a lot more time, because quality time in the visit, because there's nothing else interrupting the visit. And for patients, like many of our patients with heart failure, hypertension, diabetes, and all that, we are collaborating with the home health. So the day we are having the home health, the telehealth visit, we will have the home health nurse also go and then give us the vital signs and check the blood sugar logs, and if there is a skin exam or a wound exam, or even edema or swelling that needs to be assessed, we're getting a combination of both. And for those who don't have it, we tell them, okay, can you point the camera now to the legs so that I can see if there's any swelling in the legs, and if they have any rash, they are able to show us the rash.
Great.
It's been a really good, I think if you want to see the positives of it, it's actually been a good thing, the telehealth, for older adults especially.
Thank you, Dr. Patel. That really, again, as I said, was a super inspiring presentation, and we look forward to you participating in the Q&A that Christian is going to be facilitating. So it's my pleasure to introduce Dr. Christian Ramers. Dr. Ramers is the Chief Medical Officer for Family Health Centers of San Diego, which is a network of federally qualified health centers. So Christian.
Thank you, Bruce, and Neela, thank you for that great presentation. I'm going to finish with just one question for you, and then I've seen a lot of interesting questions directed at you in the Q&A. So once you're off the hot seat, we'll let you get to those, hopefully. This question comes from Marie Lupone, and she says, how do you deal with patients with visual and hearing impairments at a telehealth visit? She is a FNP writing in from Austin, Texas.
Okay, so it's not any different from patients who come into your clinic as well. If they're having any visual and hearing issues, for hearing issues, we've given a pad and a pen for the promoter to write, for the patient to be able to read. We've also trained our staff about talking in front of the person so that they could read the lips if there's no visual problem, but only a hearing problem. And for a visual problem, it's more just talking to them. The telehealth visit helps with us seeing everything else. If they have any edema or their environment, and it's still a visit for them, that they're happy that they have the promoter or the home health nurse going there and visiting them.
Great, thank you. And Neela, take a look at the Q&A because a lot of them are right directed towards you. Everybody's very interested. So, and I just want to acknowledge that, this 10 weeks together has been so great to see peer-to-peer learning. We've had a wonderful example from Neela, which in my opinion, turns top-down medicine on its head really. And that so many of the things you said were really just so patient-centered that, they tell us when they're ready for the visit. It's a really interesting concept that I think we could all learn from. So let me introduce our panel and then we'll get to the rest of the Q&A. We're very pleased to have some additional specialty diversity on our panel today. So Allison Brent is joining us. She's a pediatric emergency medicine physician who's a professor of pediatrics at the Children's Hospital of Colorado, University of Colorado School of Medicine. And she's currently serving as the medical director for the network of care at Children's Hospital. And she's an active member of the AAP, especially the section on telehealth care and emergency medicine. Welcome, Allison.
Thank you so much, Christian.
Thank you. Danielle Lauder is the program director of the Northeast Telehealth Resource Center in Augusta, Maine. And she leads efforts focused on implementation and growth of telehealth programs throughout New England, New York, New Jersey, and also collaborates on a national level with a consortium of TRCs. Welcome, Danielle. We have Nathan Suter, who's a dentist and owner of Greenleaf Dental Care in House Springs, Missouri, a private practice dentist based in Missouri and serves as the board chair for the Missouri Coalition of Oral Health. And he implemented the first teledentistry program in the state of Missouri, increasing access of dental care for 1,200 patients in the first year of operation, and was Dentist of the Year for his contributions to telehealth. So welcome, Nathan. We have Camilla Weems, who is joining us from the AAMC. Camilla is the Director of Strategic Initiatives and Partnerships at the American Association of Medical Colleges. Prior to joining AAMC, she implemented a number of innovative programs for patient safety and quality of care at Children's Hospital of Philadelphia, including a development of a mobile telehealth application for dermatologists. So Camilla, welcome. And then we have our old timers that have been with us before. Stephanie Roberts joins us again from the Shoshone Family Medical Center in Idaho. Welcome, Stephanie. John Scott, infectious disease doctor and professor of medicine and medical director of digital health at the University of Washington in Seattle. Randall Zernzak, a developmental behavioral pediatrician working in the Alaska Native Medical Center in Alaska. Welcome. And then I want to acknowledge a couple of other panelists. We have Elizabeth Krupinski from the Southwest TRC and Mary Devaney from the Great Plains TRC, who will be helping with the question and answer panel. So please keep those questions coming. And then Andrew Watson, surgeon. I can't believe as a surgeon you have time to join us here, but thanks for being with us. Andrew, he's from UPMC in Pittsburgh and a former ATA president. So please keep the questions coming. We'll get to as many as we can before the clock runs out. I'm gonna form the Q&A here in three main buckets here. The first will be just the new normal and how we're adapting to this and how we're incorporating things into our practice. I'll focus on Dr. Suter and Dr. Brent for the dentistry and emergency medicine perspective there. Then we'll shift to care coordination and the flow of how this is all working, how we're working through these logistical challenges of implementing telehealth. And then we'll finish with making telemedicine a part of our permanent practice and ask how this looks going forward. So let's start with the new normal. And actually, I want to ask the acute care practitioners there, particularly Allison and Dr. Suter. Allison, let's start with you. How do you do acute care medicine or emergency medicine with telehealth?
Actually, it's been an amazing endeavor, and I'm very glad to be able to share it with you. As many of you know, Colorado is a big square state with a lot of distance between our hospitals, and we have 5 hospitals in the Denver metro area, and we needed a way during COVID to really sync everybody up. So we started by addition of telemedicine to every single emergency medicine room across our entire system. And the reasons for doing this were multifold. Number one was really just to decrease PPE use. I think all of us know the amount of PPE we use, and especially in an emergency medicine setting, each time you go in and out of a patient's room, there's a phenomenal drain on hospital resources. So by enabling everyone to go in and out of a room, either nurses, physicians, other practitioners, we're currently measuring the amount of PPE we're saving. So stay tuned. We hope to publish that and share that information with you. We also wanted to allow safe access to our consultants. So they can call in from their office in the hospital, from the OR, from home, 24/7, be right in the patient's room, and provide a consultation for us. We also have the addition of peripherals that we can use to complete the exam. One of the side benefits we found with our acute care consultants is it's a huge benefit to their quality of life. They don't have to come down to the ER all the time. They can be at home, they can be in their office. So it's been very safety satisfier and quality of life satisfier. The other very nifty thing we can do is we can have multiple people consult at one time in a patient's room. Really noticeable for translation services. So we can have our translators who used to work in-house, actually hung around the ER all night. They can now work from home, so they're very happy. And we can have simultaneous, we can have a surgeon, we can have an ENT doctor, we can have a dermatologist, everybody, and the translator in any language on the same screen. So this has rapidly become a huge satisfier, great safety mechanism, and really our new normal in the ER, which we think will take hold worldwide someday.
That is just amazing. I'm speechless. I had no idea we could do those things all at once. And it really is another example of making things much more patient-centered than they have been, you know, rather than having the patient see serial specialists in a very inefficient way. Nathan, over to you. Dentistry, we did have a FQHC in the Baltimore area early on say that they were kind of chipping away at teledentistry, but how do you do telemedicine in such a procedurally oriented specialty?
Yeah, that's a great question. So there's two main ways that people were using before COVID. So before COVID, it was mostly to asynchronously do outreach programs to schools and nursing homes. And then there was some people kind of being available to consult with new patients and kind of talk to them about what they're looking for and invite them into the practice. But since COVID, there's really three ways people are using it. The main way, the ADA polled nationally dentists, and in April, 1 in 4 dentists they specifically asked if they were triaging patients directly to their home. And in April, 1 in 4 dentists surveyed out of, it was a good sized survey. 1 in 4 dentists nationally were doing teledentistry at least that way. But it did sink once people got back into practice. They resurveyed people in July, and about 12% declined about 12% that were doing that. But at the FQHCs, it's stuck at around 50 to 60% of FQHCs that are using it to reach patients, at least to triage patients. So it provides a nice way to access your patients. Since we are so procedurally driven, there's a lot of turnover of PPE and procedure rooms, and dental offices are busy beehives of staff and patients kind of coming in and going out of rooms all the time. So it's allowed for people to kind of space people out a little bit, prioritize treatment based off of their, who's more urgent or not. But now what we're seeing is a lot of people are using it, and in my practice, majority of my teledentistry at first was limited evaluations, but now it's slowly going to just catch people up with checkups. So my hygienist, she runs 2 days a week when I'm not there, and people come in and get their checkup without me even being there. And I just review asynchronously their diagnostic data and just, clear them for the next recall, or I bring them in if I see something. And that really kind of helped mitigate risk in the office. It decreased the amount of by half almost the amount of people in the office every day. And we even had an exposure in the hygiene team, and we were able to kind of keep the other team was able to carry on while they were in quarantine. So it worked out it's been working out really well. And those are kind of, you're really limited in dentistry. You're mainly, all you're able to do is triage patients, come up with treatment plans. And then the third application that a lot of dentists are finding, it's more of a convenience for the patient and the dentist is just, if a patient calls and they're like, hey, doctor said a few months ago, I had some options for this thing. They would just Zoom with them and kind of go over treatment plans. In Zoom, it's great because you can have a PowerPoint and you can kind of show them outcomes and before and after pictures of other cases. So triaging patients, maintaining your stable patients on checkups, and then doing consultations and follow-up visits. Those are the main ways people are using it.
Great, thank you for that. Those of us that work with underserved populations, we're very concerned about equity and how access to technology and the quote unquote digital divide might actually worsen access. So I want to bring in Randy and bring Neela back again. So what about those that may not have access to technology, or maybe not be comfortable with it, or may have difficulties such as non-English speakers or the elderly? Randy, let me go to you first. Working in rural Alaska, how have you overcome some of those challenges?
Well, there's first of all, the first option with VTC is to try to get into the home. If that's not available due to the lack of internet or the lack of bandwidth, we have a system of clinics with VTC equipment. And so we would either go provider home or provider at clinic to the clinic where they are. And so that's just an extra layer of coordination with the clinic in the field in terms of making sure that the room is available and that the family is in the schedule there. We've had some hiccups along those lines, so it's an extra layer of coordination. Beyond that, if that becomes not possible, then we go back to the telephone. It's not perfect, but it is better than nothing. And we will often bring in as many of our providers as we can. If it was scheduled to be interdisciplinary, we'll make a conference call out of it with such as a behavioral health consultant or a speech therapist or an occupational therapist. I have hoped that one day with coordination that we could possibly use local schools in the villages because of an even improved internet connection with the schools, but we're not quite there yet. There may be other options down the road for using other public health facilities for VTC visits.
Thank you, Randy. So it seems like, many different solutions to the issue. Neela, if you could just specifically and briefly comment on language. Do all of your providers speak Spanish, or how do you deal with language differences?
All of us do not speak Spanish, but we do use a translation system that is phone-based, and we can have the patient talk. We also use that Google Translate, and the promotoras are basically a bridge between the patient family and the healthcare team. Yeah. So many instances we would use them as well.
Great. Thank you. I want to bring John and Danielle in. There's been a couple of billing questions. I would refer you back to our billing session where we cover this in much more depth. But just as a general question, most people are just wondering what's happening next. So Danielle, what do you suggest to people that are just uncertain about how we're going to be able to bill after October 24th?
Oh gosh, have a good sense of humor, I guess. We have actually been hosting telehealth office hours every single week in our region, and we almost solely have focused them on billing and reimbursement because that's the vast majority of questions that have been coming in. Certainly we don't have a crystal ball. We know that currently the public health emergency has been extended probably out till the end of October. With flu season coming on top of COVID, I would not at all be surprised if we see another extension out through January, but that's guessing. So it's really contacting folks that are getting paid to keep on top of this, like your telehealth resource centers, et cetera. That's what we're there for. So, and keeping your eyes, on the various information that's becoming available. It certainly has slowed down a bit, which is wonderful, but we know it's probably going to tick up again as additional changes happen with the proposed physician fee schedule, for example, for 2021 that looks to really preserve a lot of what's been expanded under the public health emergency, which is wonderful. But we won't know if those are definitely a go until, you know, early 2021. So.
Thanks. And speaking of keeping your eyes on things, John, what are your go-to resources to sort of keep up to speed on when the changes are happening?
Yeah, so you know, I kind of bookmarked CMS, that web page, the American Telemedicine Association, you know, your local TRC, and then the Center for Connected Health Policy are kind of my go-to resources.
Great,
The
thank you.
Federation of State Medical Boards as well has a great website that keeps track of the cross-state licensure issues, and that's another great one.
Great. Just one other billing question back to you, Allison, regarding, you described what sounds like a multi-specialty visit where everybody could be on the same screen. How does that work in terms of billing? You're on mute still, Allison?
I'm trying to, yeah,
There you
okay,
are.
I got it. That's actually a great question. We are actually able to bill everyone, and they would just bill as a consult. So if the patient is in the ED, they actually have their ED bill drop, and then all the consultants can actually bill a consultation as they usually would. One thing I didn't get to do, which I'm currently answering a question on right now, is we also have a system where we can have an emergency medicine provider do an after-hours telemedicine visit for a PCP. And we are looking at how to actually incorporate the PCP into that process as well. So right now we're filling a need. So those patients don't always have to come to the ED, but can have all of the translator services and everything available to them, but hopefully to loop back in as our next phase with their medical home.
Thanks. And Andrew, maybe I'll bring you into this question. This comes from William England, who's the project officer of the TRCs. And he asks, allowing translators or specialists to take call at home rather than being near the ER is efficient and convenient. Does that translate to contractual cost savings that may factor into potentially more billing consultants on a case, which may improve quality, but also increase cost for payers or patients? What do you think about that?
I don't know much about the contracting with the translator services, but there are a lot of translator services that are available. And one of the challenges you have is that if your translators are proximal to the patients who get COVID, then you've got a major workforce issue. So the telemedicine translator services, there's platforms like Cloudbreak Health and many others that are very effective in doing this. It makes a lot of sense. This has been done with telephones and video for a long time, but now with the consumer electronics, it's much more efficient and effective. It's a great service.
Great. So one last question to you, John, before we move to the care coordination part, just about technologies. What are the most important technologies that you think are instrumental to implementing telemedicine?
Yeah, so I think the most important thing is just what platform you're going to be using. And I think there's been a lot of questions about that. It's going to really vary on the size of your organization, your budget. So I think one of my biggest advices is don't overspend on the technology. And also TTAC is a great resource. It's a organization run out of Alaska. And if you have questions, you can ask them and they'll give you some tips on how to think about this.
Thanks, John. So let's move to flow and care coordination. I want to bring in Stephanie to this part of the conversation and also back to Neela. What strategies have you used to ensure a smooth virtual handoff? Let's start with Stephanie working in rural Idaho in terms of handing off patients in the course of the visit.
So what we've done is we've done the nursing, a nurse going to the home and doing blood draws and that type of stuff. And they're the ones setting up that link for us to help with smooth transitions. The biggest thing is having a patient, or excuse me, we call them like a telehealth coach that will reach out to the patient either a few, 30 minutes before the appointment or the day before to make sure that we alleviate any issues as far as getting on to the equipment or and then prepping for the visit. So transitions has been better having the patient prepped ahead of time.
Great. And then Neela, in terms of coordinating between the promotor or promotora and the central office, how do you do that?
So we do have a daily huddle where our entire team, we have a Zoom call and we have also a phone number, so people can either call in or participate in the Zoom. And we discuss about especially frail patients or the calls we had overnight, if there were patients that things needed to be followed up on. We do have our care managers also as a part of the team, and that's how we get everybody on the same page. Sometimes it's also through the note in our electronic medical record, and we will send the note to a specific, like maybe our schedulers if there has to be a follow-up appointment, or to the care manager if they have to follow up on something for the patient.
Great. And another disruptive innovation, I would say, is just making us communicate a whole lot more across specialties, across systems, across hospitals.
Christian?
Sorry, who was that?
This is Nathan.
Yeah, go ahead, Nathan.
Yeah, this has been the biggest headache really around the whole process, is how to get the team to communicate, both internally and with specialists. And I've been playing with a lot of different tools, and like I found that like project management platforms are like super helpful. Like they have a lot of potential, like stuff that other segment or departments in the hospital or organization might use for other processes. Like they have a lot of the functionality built into them versus a lot of the platforms, at least available for dentists. And that's been, in the past 6 months, I think I've tried 8 different ones just to see which one works the best.
Great, thanks for sharing that. And you know, healthcare has been made fun of amongst my friends that are in tech and other industries as being so slow to uptake some of these efficiency applications. So time to join the 20th century here, 21st century. A question for Camila. I want to bring you into the conversation. Camila, your work with the AMC really has been about educating future generations about telemedicine and how to even do it. Can you share some insights on how to measure quality so we know that we're actually doing things right? And then also maybe patient satisfaction. How does a young doctor know that they're doing a good job?
Sure. So really, it's not going to be that different from inpatient visits. What we found is several academic medical centers have built-in patient surveys that trigger at the end of a video or telehealth encounter. And CAPS actually has started adding some additional questions. So, you may want to make sure you're including your telehealth patients in those patient satisfaction surveys that go out. And then also making sure your patient satisfaction surveys include questions that are specific to telehealth. But we really recognize that for a lot of schools, this is new, and I think we're still developing what good quality looks like in this area.
Thanks, Camille. And I'll have a question a little bit later more about medical students and residents for you. One last question in the care coordination section here, really for Randy and I guess Stephanie and Neela and Allison, if you want to chime in too, which is just how do you coordinate the communication between specialists and primary care folks? Randy, for example, if you do a developmental assessment, how do you get that information back to the pediatrician? Do you try to integrate them in the call, or is that too much work?
It is hard to integrate them in the call. Usually the more complicated the patient is, and the more likely are we have specific recommendations, we'll work it. Fortunately, we're connected electronically, so that helps a lot of the communication. We just set up the primary care person to enter into the visit in what we estimate to be the last 10 minutes for a quick summary. We're in a healthcare system for which most of the state, not all, within tribal health, share an electronic medical record. So it's very easy for us to, when we submit our note, we just forward it to the referring provider.
Great. Allison, in terms of getting specialists to talk to each other?
Actually, this has been a wonderful platform to get specialists to talk to each other. I'll have to tell you that before the pandemic, I've been trying to get this system in place, and it was like pushing a ball uphill. And now we really had a burning platform. I mean, telemedicine is a silver line to COVID, and it was really a burning bridge platform to get people to make changes. And once they did, they are so happy with it that I've had no trouble whatsoever getting people to engage, especially in a telemedicine platform. And what's been really wonderful is to have say, both neurology and the neurosurgeon and the translator on the same screen with you, and the nurse sees it and you see it, and it has really streamlined communication, increased our efficiency, and I think it's going to improve patient outcomes as we look down the road.
Thanks. Neela and Stephanie, anything to add? Neela first.
So UT Health, we've had this communication with all the consultants even before COVID happened, and through our EMR, we also can have secure chats. But specific to telehealth and to our visits, the telehealth visits with our common patients, we've let them know that we're going to have a visit. And as Randy said, either in the beginning of the visit or the end of the visit, we'll have them participate. And if they cannot, or if they do also, we still copy the note to them and send the note to them.
Thanks. And Stephanie, in rural Idaho, is this an issue for you as well?
Yeah, it's actually a more difficult issue to gauge. So for us, we do a lot of work with our care coordinators as trying to kind of connect those boxes. We do send notes, but getting consults at the time of the visit, we're not there yet.
Okay. Good. And I mean, I think it's okay to admit that we're learning along the way. Somebody said earlier, humor gets you through, humility. We're all just kind of working together here. So let's move into yeah, Andrew, go ahead.
I work in the inflammatory bowel disease medical home, where we actually have nutrition, social work, GI, surgery, and psychiatry all together. And obviously now we can't do that. And so we're using a lot of multi-party calls where the patient joins an Epic video room, and one of us joins and the next one joins and I leave, and we kind of cascade down the row. We also use a lot of Zoom to bring the medical home together to have all these multidisciplinary talks. We're having some challenges about how best to message between the video calls, as someone else pointed out as well, because you can document in the EHR, but it's a little bit more cumbersome. So for like just quick messaging, when we're all together, it's simpler, but because we're using video right now, it's a little bit harder. But overall, it's very effective for care coordination, and it's a great medical home model that we've been lucky to participate in.
Thanks, and you're getting accolades from the chat. Bettina Bernstein says that telehealth has broken down these artificial barriers between patients and clinicians. Well said. So we'll move into the final part, which is looking forward here, how to make telemedicine part of your permanent practice. I want to bring Danielle and John in for this question. We've talked about workflow and the optimal mix of in-person versus telemedicine visits. Danielle, what do you advise some of the people in your area about how to approach this?
Sure. So there are certainly preferences and things that work better in some environments than others. Some folks, and this was even pre-COVID, much preferred with their particular environment to do block scheduling, for example, and they would really designate, and it means somebody being dedicated to filling up that block schedule, right? Especially if you have a contract with a specialist or whatever service need there is, so that you're continuing to bring in the revenue, utilizing just key tips to make sure that you're not having no-shows, although telehealth, especially over the last few months, we've seen massive decreases in no-shows, right, which is another silver lining. So it's making sure that you have those things in place in making the schedule work. We are getting lots of questions now with that folks are coming back into the office, and we've heard from folks saying, well, we have Zoom exhaustion or video conferencing exhaustion, right, whatever the platform is. How do you balance and making sure that you're meeting the needs of your patients? You're going to have clients that are more interested in doing telemedicine moving forward than they are in person. So just really looking across your patient panel and making sure that you're meeting those needs and balancing those needs with your providers, so that there's not overwhelming use of the telemedicine. So I'll turn it over.
Thanks. And John, if I could change the question just a little bit before you answer it, how do practices remain adaptive going forward to all the changes?
Yeah, well, I agree with what Danielle was saying, that it's good to probably have blocks where you're doing telemedicine and then in person. I just think there's a lot of cognitive switching. And the other thing is, patients don't like to wait on a telemedicine call. Like they're unfamiliar with the technology, and they get really anxious if they're waiting for more than 10 or 15 minutes. So just make sure you're checking in with people if the provider's running behind. And then the thing that I've heard from a lot of other academic medical centers is people are titrating to about 20 to 30% of their total ambulatory visits to being telemedicine. So if that helps, some specialties are going to be less, some are going to be more. And then how to be adaptive. I mean, I think part of just being aware of what's going on with COVID in your community, we've kind of seen a pretty tight correlation with, as cases go up, more telemedicine is happening. So just that's a real tangible way how you can be responsive to what's going on in your community.
Thanks, John. So I want to turn to Camila, who with AAMC represents our future, our future providers. So how do you approach at the AAMC training medical students and residents in telemedicine?
Sure. So we actually just recently released telehealth competencies. So with a really broad range of education stakeholders and those with expertise in telehealth, developed tiered competencies across the continuum for undergraduate medical education, graduate medical education, and continuing medical education. And what this does is providing, we recognize that providing telehealth right now is critical now more than ever. And so these competencies are designed to basically help people know, what should a graduating medical student, graduating resident, and faculty know in certain areas of telehealth, really ultimately in improving healthcare and outcomes. So they're intended to guide educators while developing curriculum for students learning practice, and for professionals learning. At the very beginning of this pandemic, we stood up a collection in iCollaborative on clinical teaching and learning experiences without physical contact. And that just has hundreds of resources on how teaching hospitals and academic medical centers are adapting, and some experiences and expertise on how some hospitals have been doing this for a few years. So, there's many different examples in there, whether it's, George Washington University, which is, they have rotations tailored to individual telemedicine interests, like mobile patient monitoring, or Cornell, which has an elective for four-year medical students. So what we're seeing is that there's, a lot of schools out there that have a bit of an established curriculum that, we're learning from, but then there's, a lot of schools that, as a result of COVID, we're sort of thrown into the fire and have developed really interesting curriculum over the past 6 months.
Thanks, Camila. And two people in the chat beat me to my follow-up question, which is where can we access these competencies? If you wouldn't mind just putting any kind of link in the chat, that would be great.
We'll do right now.
Okay. All right, so we have just about 2 minutes left for me to do a lightning round at the end. So all of our panelists, I'm going to pitch this one to you, which is, what is your #1 piece of advice to practices looking to implement and sustain telemedicine? Keep it short, only got 2 minutes. John, we'll start with you.
Christian, can you repeat the question? So I've been trying to do the chat.
What is your #1 piece of advice to practices looking to implement and sustain telemedicine?
Well, I think just #1, just get started. And I would maybe start with follow-up visits. That's a really low risk place to get started, and maybe do it with types of visits where there's maybe a behavioral health type question or follow-up of lab results or imaging. That's a really safe place to start.
Thank you. Randy, over to you.
Don't be afraid, embrace it. It's our future.
Thank you. Nathan?
Yeah, I'd say don't give up after the first one. It's going to feel pretty foreign at first. So take a small sample and trudge through it.
Excellent. Danielle?
Echo everything so far, but start small so that you can work out the kinks, right? Know your population, and contact your telehealth resource centers, because we don't want to have anybody having to recreate any wheels, right? None of us has time for that.
Excellent pitch, and we'll help you pitch that in the closing here. Stephanie, over to you. #1 piece of advice?
Prioritize time in your schedule, whether it be at the beginning of the day, at the end of the day, but prioritize time to make it a priority, or it won't ever happen.
Great. Neela?
You could have designate a clinician or physician or nurse practitioner to be doing telehealth visits, so you can balance out the time for telehealth versus face-to-face visits.
Okay, we'll go to Andrew, and then Camila, and then Allison to finish out. Andrew?
You just be verbose when you're talking to them. Explain what you're seeing so they can understand that you're actually conducting an examination. And also use a lot of humor. I mean, patients like it, just the same as face-to-face.
Great. Camila?
Learn from others. There's so many people that are doing this, so don't think you have to reinvent the wheel. Look to see what other people are doing and what's been going well for them.
Thank you. And Allison, the final word?
My mantra has always been that remember, telemedicine is just good medicine.
Great. Well, thank you so much, everybody on the panel. Thanks everyone who has been a loyal participant to the bitter end. I'm going to turn it back over to David and Darren. Thank you, Bruce, for helping facilitate. Thanks everyone for being involved. And thanks to our ghost panelists as well. David, over to you.
All right. Thank you, Christian. And thank you so much, Dr. Patel, for the inspiring case study. I think that was just the perfect way to end our series. And thanks again to all the panelists for a very lively, interdisciplinary Q&A session. And so I just want to remind folks that for this last session, we're extending the time till 1:15 Eastern time, 15 more minutes. There's a little bit more to go over in terms of announcements. If you can't stay on for the full 15 minutes, we've tried to be as very detailed with the information about the end of course survey, as well as how to obtain a training certificate. So you should be able to get that information from the slides as well. But if you are able to stay on, we'll be able to provide a little bit more detail. But before we get into the announcements, since it is our last session, if I may, I wanted to just take some time to thank the many partners and folks who helped to make this series possible. And if we can go to the next slide, you'll see some of the key partners. And first of all, I want to acknowledge our team here at HHS Asper. I think you guys know that this initiative started as part of a COVID working group. Our working group, which was called the Healthcare Resilience Working Group, was really tasked with supporting healthcare systems around the country. But for the first 3 months of the pandemic, we really focused on hospitals, EMS, critical care, ventilators. A lot of the main issues that we were seeing with COVID were in those spheres. And so the ambulatory providers were pretty much neglected, at least by our working group, for the first 3 months. And so when we came in, we did a lot of interviews with stakeholder groups and associations to see what ambulatory providers needed. And what we heard over and over again was telemedicine implementation. That's how this series came about, was because in the ambulatory world, you weren't seeing surges of patients like they were seeing in ICUs and EDs. You were seeing decreases in visits. And how could you continue to maintain that quality of care with your patient population moving forward? Telemedicine is really a big part of that solution. So that's where it came, and the working group, I know you're only seeing, Darren and myself on screen, but there's a whole village of us that are supporting this community. And so I just want to acknowledge folks like Israel and Farah, Megan, Janine, Marie. There's a lot of folks that are doing things like finalizing documents, posting things to train, developing the survey, answering the resource box. There really is a team of us working on it. And then, of course, Project Echo. I mean, it's just amazing. This is the first time that, even though I've attended many Project Echo sessions before as a participant, first time I'd really worked with them. And I think it's very clear, from these series, those of you that have been participating, they bring a level of professionalism and attention to detail that really elevates this content and makes it shine. So I'm really appreciative for all the things that they brought to the table. And we've had weekly sessions, planning sessions with them for even a month before this series started. And it just has been amazing to be working with them. I also want to thank Train. Train is so important because they're our resource. Some people asked in the chat about the Telemedicine Hack resources. They're always going to be on Train in their course catalog. So any one of the 2.5 million registrants on Train, if they search for telemedicine courses, they can maybe find Telemedicine Hack. And this can be, a year or two from now. People can binge watch this like a Netflix series if they want to do that. And it'll all be there as a resource. So we're really so thankful for them, for all that they've provided. And then finally, with the TRCs, I mean, I know, Mary and Elizabeth and Danielle are the only representatives of the TRCs here today. But of the 14 TRCs, I look back and I think 9 or 10 of them have participated in this series in some way, either as didactic speakers, as panelists, back-end panelists, and they're going to do a great job, I know, moving forward, carrying this community to the next version. And so with that, I'm going to hand it over to Darren to talk a little bit more about that transition.
Yeah, thanks, David. Next slide, please. I just wanted to say personally, as a public health service officer, I am generally downrange, running community-based testing sites in Texas, or a deployment team leader for rapid deployment force running federal medical stations. So this has been a really big change for me. I really appreciate our community and our partners. It's been a really good collaboration, and I'm very thankful for being part of that. So what's up next? HRSA Telehealth has a telehealth HIV series that is coming up on the September 29th. Partnership between ASPR and HUD. They have a telehealth community-based organization. The next part is on homelessness and connectivity. And then, as we referred to several times throughout this session and sessions prior, our partners at TRC, we're handing over the reins to them. They're hitting the ground running right out of the gate here. Their first session is going to be on telehealth technology and trends. And then their second session is a little dear to our hearts because these were original participants and have participated in all 10 of our sessions for the TM hack, and they felt moved, and they're actually following true to the form of a TM hack, and have 2 case presenters and also a didactic presenter. Next slide. And then just to close out my section, I'll turn it over to David. Just please consider prior sessions and updating as we update our discussion boards on the Train website. This is where you can continue to get to view these sessions. Remember, you need 8 to 10 of these sessions to be eligible for your ASPR certificate. And then my last pitch, because if I need you guys to take the survey. This will be good feedback for our peers and our telemedicine community. And that's my closeout. And David, back over to you.
Great, thank you, Darren. If we can go to the next slide. I'm going to walk through the process about the surveys and the training certificate. And as Darren and others have said, we started this initiative with a lofty goal of getting at least 90% of participants having conducted and billed 1 or more video-based telemedicine visits by September 30th, which is 1 week from now. And the end of course surveys are really our way of trying to assess that goal and to get a better sense, whether or not this initiative had the impact that we hoped that it would. So we really encourage folks to complete the surveys. Now it's going to be a little bit tricky. I want to walk through the process because there's a couple things going on. So if we go to the next slide. What we decided as far as trying to make things easier and not have too many links and people having trouble keeping track of what link is we have really 1 link for you to access for both the surveys and the training certificates. And then the additional surveys and tools are embedded within there as you complete the initial survey. So I hope this is going to be helpful and not confusing for folks. But what we have here is our first, what we're calling survey part 1. And this is very similar to the baseline and midpoint surveys for TM hack that you guys may have participated in if you started from the beginning. And it's a little bit expanded because we're adding additional questions about the course structure and the organization of TM hack, but not too many extra questions. And this is all going to be run out of HHS ASPR. And so the hyperlink here on the slide, and we're going to share it in the chat as well, is how you access the survey part 1. When you submit your answers for survey part 1, then you'll receive a thank you for completing the survey, and it'll also provide the link for survey part 2. And so this part 2 is a survey that's approved by ECHO. So as you know, ECHO is one of our key partners for this series. They have their own end of course evaluation, standardized questions. We want to make sure that we capture the effort of Telemedicine Hack in terms of how they're tracking their courses in a standardized way. And so we really want you to take that survey as well. We estimate that between both of them, it might take 15 to 20 minutes, not too long. Hopefully you can really get a sense, and it'll be information that we use. We share with HHS leadership. ECHO, of course, will use it. We'll also share with the TRC to help inform the 2.0 version that hopefully many of you will participate in. Next slide. And then as far as the training certificate, I know I saw a lot of questions about this in the chat. And, the way we're doing this too, again, is trying to make it all streamlined, is after you complete the part 2 of the survey through Echo, they'll have a link at the end of their survey as well, which will, collect some information, very simple, documenting that you attended at least 8 of the 10 sessions, and they can be a mix of live or recorded. So for example, if you haven't, had live attendance for 8 of 10, you can go to Train, you can go to the Echo site to watch the other ones. And if you have attended or viewed at least 8 of them by Wednesday, October 7th, then you can, in that link that's at the end of survey part 2, enter your information, and then we'll shut down that link on October 7th at 1 p.m. Eastern time, and that'll be the master list of folks that we'll send training certificates to. And, given the community of this size, we don't know how many of you will request the certificates, but, just to be on the safe side, we're only going to do electronic certificates, and we'll mail it to the email address that you put in that link. So it should be hopefully fairly straightforward. Now, if you or other colleagues, want to check out Telemedicine Hack later after October 7th, then you can get a training certificate actually through the Train system. It'll be a Train-generated learning certificate. It's a little different than the ones that we're going to be giving before October 7th, because the ones that we'll be giving through this link is HHS branded certificates. So that's the difference. I just want to make sure that there's opportunities for certificates, even in the future. Next slide. And again, just as a reminder, this is a slide we have for all of our sessions, but there is a user guide here on the screen, walks you through Train, how you can get through the discussion boards and the materials. Next slide. And I think for the main things I want to highlight with the discussion boards is the 2 that are going to be most probably important moving forward as kind of a library of our resources is the slides, recordings, and session materials discussion board. Everything goes there. The slides, the recordings, the Q&A transcripts, the TM Hack, top 5 cheat sheets, meet the panelist profiles, everything will be in this one folder. And then we also have a bonus hack folder, which we had one bonus hack on telebehavioral health. The recordings, the Q&A transcript, and slides from that session are in the bonus hack folder. Next slide. And then just as far as the summary for the community, I personally, this has been just an amazing journey. I've really enjoyed being part of this initiative. It feels so good to contribute to something meaningful, to be part of a team. Thank you so much for all of you for attending. When we first started this, we were hoping maybe if we got 100 or 200 folks that could complete the whole series, that would be asking a lot from private practice docs and other folks who are extremely busy. And to see the numbers that we had on a sustained level from such a diverse numbers of specialties and types of practices, it really made all this worth it. So I really want to thank all of you for taking the time over these 10 weeks to participate. And just as a highlight on the left, you can see a map. We had a total of 58 presenters and panelists, if you count our bonus hack over the series. These presenters and panelists came from 27 states and the District of Columbia. Physicians, nurse practitioners, PAs, occupational therapy, dentists today, surgery, billing consultants. We really tried to make it diverse. We tried to bring the experts to you. And they came from different settings. So we had several folks from FQHCs, one rural health clinic. Stephanie's representing that clinic from Idaho today. And folks from private practice and from universities. And then on the right, just as far as really keeping track of the community, we had an average of 1,700 attendees over attending on average per session from all the states, 3 territories, and I think at least 20, 25 countries as well. And we had a nice mix of about 55% providers and 45% non-clinical, representing over 45 different specialties. So really, this was really the whole kind of all the different strata of life from the ambulatory world. We're part of this community. And again, I really am just so honored to be part of it. And thank you so much. I'm going to turn it over to Bruce to see if there's folks from the ECHO team that wants to say some words.
Great. Thank you, David. Just want to say it has been a total honor and pleasure for our team to collaborate with the HHS team and with all the partners, with the TRCs, with our different, as you said, 58 different presenters. It's been an incredible journey. I think it has been much more successful. As ambitious as we were, it's been even greater in reality than we were imagining. So I just want to thank Amy and Amanda and Patrick on my team here at Project Echo, who have been supporting it from our home base, and Christian Ramers, who's been the facilitator par excellence, and John Scott at University of Washington, who's been participating in all these sessions. And Christian, do you want to say a word?
Just briefly, I think we've seen the power of collaboration, and I think it's going to be very important as we move forward, even though the future is incredibly uncertain. Hopefully we've seen that learning from each other is the way to go. So thanks for the opportunity.
And David, just want to say, this was phase 1, and phase 2 with the TRCs. We're excited to see that move forward. So best of luck with that, and we'll look forward to helping however we can.
Thank you very much, everyone.
Yeah, take care. Thanks to our panelists today, and be well and keep innovating.